To master diabetes drugs, you must understand the pathology divide. Type 1 diabetes is an absolute insulin deficiency due to autoimmune beta cell destruction, so treatment is strictly lifelong insulin therapy. Type 2 is a dual problem of insulin resistance and a relative insulin deficiency. Here, we use oral and non-insulin agents to sensitize tissues and optimize the pancreatic systems that are still running. Let's break down the insulin kinetics matrix using 3 high-yield mnemonics. First, rapid insulins. Lispro, Aspart, Gluthazine do not lag. Because they don't lag, they cover meals instantly. Short-acting is your regular insulin. Intermediate, NPH, is not particularly hasty. It peaks gradually. Finally, long-acting, Glargine and Detamir, last a good deal of time, GD, giving you flat, peakless basal coverage for 24 hours. Metformin is our first-line oral therapy. It works by inhibiting hepatic gluconeogenesis and increasing peripheral glucose uptake in muscle. While GI upset is common, remember the mnemonic MET. Metformin can cause MET-AT, metabolic lactic acidosis, in renal failure. Clinical Pearl. Always hold metformin for 48 hours before and after IV contrast to protect the kidneys from injury. Sulfonylureas end in "ide." Think "I'd take your sulfonylurea." They act as insulin secretagogues by blocking ATP-dependent potassium channels in pancreatic beta cells. This depolarizes the membrane, opens calcium channels, and squeezes out insulin. Because insulin is pushed out independently of glucose levels, the major risks are weight gain and a high risk of hypoglycemia. Meglitinides end in Glyburide and share the exact same potassium channel blocking mechanism as sulfonylureas. The key difference? They have a much faster onset and shorter duration, meaning they must be taken right before meals. If you skip a meal, skip the dose. Think of a pageant queen, Repaglinide, getting nervous and hypoglycemic right before going on stage. DPP-4 inhibitors end in Gliptin. Remember, Liptin T makes you PP 4 more times. Normally, gut-released GLP-1 stimulates insulin, but the DPP-4 enzyme acts like scissors, cutting it up. Gliptins block these scissors, keeping natural GLP-1 active. Because they only work when you eat, they are weight neutral with minimal hypo risk. Watch for minor upper respiratory infections. GLP-1 agonists end in tide. Think gulping Tide Pods is dangerous, just like GLP-1 agonists end in tide. Instead of just stopping breakdown, we inject a highly potent GLP-1 mimic. This heavily tips the scale, boosting insulin, suppressing glucagon, and delaying gastric emptying. Slower gastric emptying leads to early satiety and significant weight loss. Watch out for nausea and the risk of acute pancreatitis. SGLT2 inhibitors end in flozin because glucose flows in the urine. They work in the kidneys, blocking glucose reabsorption in the proximal tubule. This dumps excess glucose directly into the urine. While this renal drain promotes great weight loss, all that sugar in the urinary tract significantly increases the risk of UTIs and vaginal yeast infections, alongside osmotic diuresis and dehydration. Thiazolidinediones end in glitazone. Think, bring glitter to the party. Glitter for glitazone and party for the PPAR gamma nuclear receptor. TZDs are powerful insulin sensitizers that alter gene transcription to upregulate glucose transporters. Because they alter DNA expression, their clinical effects take weeks to develop. Watch out for weight gain and fluid retention. TZDs are strictly contraindicated in heart failure. 2 adjunct tools to know. First, Acarbose blocks alpha-glucosidase in the intestine, stopping carb breakdown. Acarbose leaves you acarb, without carbs. This causes classic side effects of flatulence and abdominal cramps. Second, Pramlintide is an amylin analog injected at mealtimes to slow gastric emptying.
Used alongside insulin, its main risk is severe hypoglycemia.
This master cheat sheet is gold for clinical exams. Remember how these classes affect hypoglycemia and weight. Metformin and DPP-4s, gliptin, are weight neutral with low hypo risk. Secretagogues, Glyburide, and TZDs, glitazone, cause weight gain. Secretagogues carry the high hypo risk. GLP-1s, Tide, and SGLT2s, Flozin, are your superstars for weight loss with low hypo risk. Let's put this into clinical practice. If a newly diagnosed type 2 patient has an A1C over 10% or is highly symptomatic, initiate insulin immediately. Otherwise, start with metformin. If they don't meet targets, assess comorbidities. ASCVD? Add a cardioprotective GLP-1 or SGLT2. Heart failure or CKD? Choose SGLT2 for its heart and renal protective dream. No comorbidities? Select based on weight goals or cost. If you enjoyed this, please like, share this video, and subscribe to Clean Med KE so you never miss our clinical review videos. Let us know in the comments what pharmacology topic we should cover next. Thanks for watching, and see you next time right here on Clean Med KE.